Well, since I'm chairing this, I'm going to take the first question. And I think I'd like to, since we've talked a lot about mortality and vitals, I'd like to talk a little bit about morbidity and specifically about some of the questions that came up in Puerto Rico. And that is the population, either disabled population or those who are in a variety of needs that probably wouldn't be covered by reportable diseases, but Florida does have an older population, people like me and older, and how do you measure the impact on those folks who would have possibly negative outcomes a week, 2 weeks, 3 weeks, 4 weeks afterwards?
So most of our activities that we do in my unit is focused on the acute response, where we have the ability to do public health interventions. We've done some studies working with some of the folks here, looking at delayed mortality, for example, and other impacts from the storm in a more of a with a more sort of academic approach, but most of the work that we do is focused on those real-time acute issues where the immediate intervention is needed.
Ken, do you geocode all your vitals?
We do geocode. We have a separate section in Tallahassee. We'll record the data, get it in. It goes to our other data group in Tallahassee, and they do geocode the data.
When does that happen?
It is usually, our births are registered within 1.5 days. Deaths about 4.5 days after the event. I would say within 7 to so days we have geocode.
And do you geocode place of the event or residence, or both?
I think we do both.
Okay. Do you see a need to have those types of geocoding systems directly connected to your EDR? Or?
It's something, we're doing an upgrade right now on our EDRS, and that's in the discussion.
Okay.
As to will that be included in it, or how we'll wrap it back into how we geocode. And then we also have our chart system that we put the data out on, how that's going to interface with that also.
And how granular is this geocode?
That I can't answer because I'm not doing the geocode.
Okay.
Sorry.
Okay, that's okay. For everybody else, questions? Yes.
Dr. Nelson, you mentioned that you'd speak about the methodology later, so I would love to hear about the methodology for reporting, the requirements for information, the essential elements information you ask your medical examiners for, and then timeline and system.
Timeline and system is easy. We report twice a day to the State Emergency Operations Center. That's the central repository for how information is distributed to the media. So the medical examiners get the data from a whole host of sources. Typically it's law enforcement. They're the first responders to the scene. They report to the medical examiner. Medical examiner is responsible for providing transportation of the decedent into the office. And it's up to the medical examiner to determine what the cause of death is based on the historical information that's provided by law enforcement.
And thanks to you all for, and not only from the learnings that we've gained from you in past disasters, but for being an ongoing proving ground to these methodologies going forward. I just hope that you're not too impacted by Dorian next week. But you all have really led the nation in developing some of the more sophisticated systems for some of these things, and we're grateful to that. We also need to remember that unfortunately they're not as prevalent in other areas, but they certainly can serve as a good model. Thank you.
If I could piggyback onto that, after 9/11 with the DMORT system, Florida established its own emergency mortuary response system, understanding that the feds would not be there to help us probably for a good 3 to 4 days. So we've established our own system in Florida of mutual aid for mortuary response. It was most recently tested with the Pulse nightclub shooting in Orlando. All of those victims were autopsied and ready to go to the funeral home within 2 to 3 days. So that's in addition to the regular enormous workload that the Orlando Medical Examiner's Office has. But we have a disaster mortuary response system within our state. It's administered through the University of Florida, where there are pathologists, there are funeral directors, there's equipment, temporary morgues, all such equipment that's ready to move, and it was moved up to the Panhandle with Hurricane Michael. So again, we're not relying just on the feds. We know that there's a period of time from a disaster before any outside help arrives.
Thanks. I'm a Florida Panhandle native and grew up on the beaches of Panama City. My mother-in-law lives in Mariana, had her house destroyed after Michael. So thank you guys for being here. I wanted to ask Dr. Nelson, you mentioned that you're still counting Michael deaths. Could you tell us a little bit more about that? Are those direct deaths, indirect deaths? Is that a delay?
They are the most recent death was an indirect death. And again, proximity is what starts the ball rolling. So if somebody is injured, for example, during post-hurricane cleanup, they develop noxic brain injury, they're in the hospital for a long period of time, and then they die, those are counted as an indirect death as a result of the hurricane. So there is no time frame on, even though the governor's executive order has a time frame on it, the governor's executive order is when we start counting. We don't put a time frame on it as to when we stop counting.
Thank you very much to the panel. Craig Fugate and Rich Serino used to tell me how awesome Florida is, and that's clearly on display. All right, Craig may have. Rick's too busy talking about how great Boston is. Couple of questions. First, a comment. So there's a dimensionality to deaths, right? There's total deaths, which is a static number, which helps you understand the magnitude of an outbreak after the event. But there's also a dynamic feature of deaths, which is sort of daily deaths. What's going on, how to use that data for surveillance or other purposes. And the daily death part really gets to this sort of attribution issue. So really for Dr. Nelson, others on the panel, and this goes, and Dr. Blackmore, this also goes to morbidity. It's sort of this attribution issue. So, when you say you report deaths twice a day to the incident command to then be shared with all the responders, is that the direct, indirect deaths, or is that all deaths? And then back to you, Karina. So, the essence is really about, as you said, epidemic preparedness, right? So that's not, I missed my dialysis and I'm in acute renal failure. That's not, I didn't get my insulin and my diabetes is out of control. So how do you deal with that attribution issue? And I guess, Dr. Nelson, to you, it's sort of that same issue of attribution. Because you talked about a minute ago, somebody had an injury and then, months later you connected it back. But that doesn't take care of all of the other chronic conditions that may have been a function of Michael, for example.
We do not, we freely admit, we do not count all of those deaths. If somebody dies just because the storm is coming ashore, those deaths are not counted in our death toll. What are counted, though, are those that are preparing for the storm. They're cleaning debris, they're putting up storm shutters, whatever they're doing. They have head trauma as a result of that, fall off a ladder. Those are all counted, whether they're pre-impact or post-impact. But we are clearly not counting the folks that die from AIDS during a storm, people that die from Parkinson's disease during a storm, as you say, heart disease, somebody that doesn't have their insulin, they're on renal dialysis. No, unless we can make a very clear connection to that, no, we would not count those.
So Sandon can also comment on this, I think, because how Florida deals with understanding the needs of the community for medications and so forth, I think differs depending on the situation locally. We have helped from a surveillance perspective or an epidemiological perspective, working with our colleagues at CDC doing CASPERS, these surveys in communities in the past. one that comes to mind was in a high-rise in Broward County in 2005, I think, after one of the storms that went through there, that had a number of elderly individuals in the high-rise, and we did have particular concerns about their access to medications. And I do believe that we identified that there was, at that particular time, was not a big a need or a gap in services. I do have to say, though, that I think in an acute setting, we've had less of success with Casper than we've recently used it actually to assess risk for suicide related to Hurricane Irma. A year after the hurricane, and I think that's a really valuable use for Casper. Right after the hurricane, what our experience has been when we've deployed it, which may or may not have been always the right places, is that people are more mad about not having their cable TV and so forth. There haven't been real needs that have been identified that way. Sandon, if you want to comment.
I can follow up on that with what Dr. Blackmore said. At a local level in Bay County, what we initiated and implemented about 5 years ago, and it's been very successful, is a special needs registry where we have actually gathered data of those individuals, of those vulnerable adults that may be responding to the special needs shelter when it's open, because the health department, for those of you who don't know, are responsible for manning and staffing special needs shelters throughout the state of Florida. And then you have other agencies, Red Cross, other agencies that man the general population shelters. So that is something that we've really refined year after year to pare that down, to make sure that those individuals that qualify and are candidates for that registry are on that list, so we can reach out to them, to engage them, to make sure, how are they doing, or are you planning to come, or you're not planning, and that's been a good thing for us as we prepare, and we have that list that's pretty true and accurate. So we continue to work on that.
So another community that comes to mind was Everglades City, and that was also after Irma, a community that is still, I think, fairly isolated, and with relatively little interaction with the health department and the government in general. So a fair amount of direct outreach to essentially every home in that community, to make sure that we understood what the healthcare needs were, make sure that the persons who had not gotten tetanus shots got tetanus shots, because one tradition in this community was to walk barefoot, and we were concerned about injuries that were associated with the debris after the hurricane. So not very sophisticated scientifically, but that human touch with those communities.
So, the satellite imagery of the destruction in Mexico Beach was just absolutely astounding. And I was wondering if you had, when you see the complete loss of buildings, whether first responders had gone to those and done sort of a lot-by-lot assessment or check for people who had not evacuated, and whether those figure into mortality statistics.
I probably can't speak to that directly because I was in Marianna. I was serving in Jackson County, but you're exactly right. Seeing the pictures and the devastation of Mexico Beach, ground zero, where there's just nothing there. I do know that in Bay County, after a day or two had passed, that we actually deployed our mobile medical buses, our mobile dental buses to that area, and provided vaccinations. We provided flu shots, tetanus, and Hep A, and I shared that with Dr. Blackmore because our state is in the middle of a Hep A crisis right now. But we were ahead of the game with that, and the staff and those responders were there. We also received strike force teams from Tallahassee. Environmental health personnel came in as well. I don't know if that answered your question or not. I'm sorry, but I just, again, I was not there exactly with the boots on the ground, but and actually didn't see a lot of that coverage for several days because we were, just without. You know, it was really something to experience. But yeah.
Okay.
So I want to go back to something that Steve Nelson, that you started us off with, which is the story of the barge. So I was living in Boston at the time. I remember Andrew pretty well. I'd never heard that story. But the idea that there would be an urban myth around, the government trying to cover up the number of people who had died is not entirely shocking. And I guess one of the things that I'm curious about is, that's a reflection of some level of mistrust. And it's probably a mistrust that is founded on a vague understanding that there are incentives in place to either under or overcount mortality and morbidity by different players in the system. And I'm wondering how so I guess number one, do you still now, 25 years later, see that kind of mistrust as an issue of the numbers and the incentives that different stakeholders face in terms of over or undercounting morbidity and mortality? And number two, what are the strategies that Florida has maybe put in place to try and mitigate that mistrust, to make these numbers more trustworthy, right? Worthy of public trust?
Well, when I started my presentation, I did not say I'm here from the government and I'm here to help. What has Florida done to mitigate some of those? I think our statewide reporting system, we no longer allow individual county, individual localities to count their dead. All of their dead now go through the medical examiner offices and through the State Medical Examiners Commission for reporting. Even with regard to Michael, we had one county, I don't know if it was Jackson County or one of them, there was all kinds of rumors. There's 30, 40 people dead up there. It turned out not to be the case at all. So again, there's one group of reporting. If, and this hasn't happened in a while now, but if we learn of individuals that are individually reporting, whether they're at the county level, the district level, or whatever, they get a telephone call and they're counseled that that's not to happen, that the official death count will come from the Emergency Operations Center in our state capitol, and it'll be released every day a little after 4 o'clock every day. So I'm happy that you didn't hear about the death barge that was off the coast of Miami. I think the official count for Andrew is something like 65 dead. The death barge held 300 plus people. So again, the accurate reporting is very, very, very important.
You want to tell them about the test you gave me this morning on the numbers?
When I knew I was coming, I sent Ken an email asking him how many people had died as a result of Michael. What I didn't tell Ken was I then asked my commission staff to tell me how many people had died from Michael that were reported to us. And I'm happy to tell you folks that the numbers matched. So, there shouldn't be... There shouldn't be any discrepancy in those numbers coming from one source. So that's what we hope to do away with. As I said earlier, Andrew was 1992. We didn't get that system in place until 1998. So there was a few hiccups as to what we thought was best reporting practices in the state. But it's in place now. It's been in place since 1998. And that's how we work with any disaster, not just a hurricane. We've had executive order disaster declarations when we had wildfires. So the same things apply. When the governor says there's a disaster and makes an executive order, that's when counting starts.
I wanted to come back and ask both Karina and Sandlin to share with the committee an example of how you use data to implement real-time public health interventions at a community level.
So I think that the most important example for us is carbon monoxide poisoning. We learned after the 2004 hurricanes, that's really when we realized that we had an issue with carbon monoxide poisonings, and we did then put out public messaging and so forth to educate the public about carbon monoxide poisoning. Since then, we have made carbon monoxide poisoning reportable, so we actually monitor it at all times. And then we have developed communication packages that we then share before storms and have available on our website. We've also worked with companies like Home Depot and Lowe's to add information about carbon monoxide poisoning and the importance of carbon monoxide detectors to when they sell generators. Not a perfect system, but we have made some inroads and to try to again get that message out to the public about the importance of this silent killer.
I think from a local level, Dr. Litchfield, the data in our WIC division, the Women, Infant, and Children division, the storm created a significant negative impact on the number of participants in that program, a 30% decrease as a result of Hurricane Michael. So that's a lot of moms and babies and possible pregnant women that went missing after Hurricane Michael, and that was very significant because the health department has such a robust WIC program and always has had a very robust WIC program and responsible for covering multiple counties as well, not just our own county, but other outlying counties. So that data was very important for us to see where we need to take that service line, how we need to improve it, how do we need to re-engage our community to let those moms and families know that WIC is still here, and also trying to help relocate where did they go? Did they relocate? Did they drop out of service? So I think that's something that we're 11 months later, we're still, trying to get a good handle on that and see where we go from here with that particular program.
Thank you. And, contrary to what Allie believes, Florida is pretty good. Is listening to everything you said, and you essentially are a model for a lot of the country, various states, and you've done some great work and you've given some great tips that all of us have been taking notes on. But if you had the opportunity to rebuild or start again, both from the local level and for each of you, one of the committee's charges is to look at how we can utilize the best resources going forward and how we're able to make recommendations. What else would you do that you don't? You have a great system, obviously, but what do you not have that you would say would put you over the top a little bit more for each one of you?
On my wish list is a statewide computer-based, cloud-based data gathering system. We have 25 medical examiner offices in the state. They report to the State Medical Examiners Commission, but they're individually inputting data into their own data management system, for want of a better term. And then we also have to enter data, again, similar data, into Ken's system. That's duplicative. That's a waste of time in my mind. Ken and I are working on that to make that less onerous on both of our parts. But if I had a wish list, that would be right up at the top of my wish list, that when we enter data, we enter it one time and it goes to everybody that needs the data.
Yeah, if I may. Same as Dr. Nelson said, we do want to, in vital statistics, we're upgrading our system now. It's a Citrix-based system. We want to go full web-based. What else can we do above that? When we have outages, the systems are out. We're still looking for those methods of being able to collect data other than paper. That is our fallback too, but it's not a good fallback. So we're still looking at that alternative. As Dr. Nelson said, we do want to look at automating our medical examiner commission system to create a death hub so that not only I can pull data, our ME Commission can pull data, but we can send it everywhere. We don't have that. So we're looking at how to fund it. I'll look over at Steve and say, thanks, Steve, one day. But, you know, where else can we try to go from there? And from the reporting side, that's really, you know, what we're concentrating on.
So we certainly dream about and are working towards electronic case reporting, which I think will benefit, being able to upload data from mobile devices, especially during our field investigations. We do some of that, but there are some glitches at times. I think the biggest vulnerability that I believe we have is that we are also very dependent on federal funding to maintain these systems, and potential gap in federal funding could set us back very quickly.
I'm just thinking about communications, and I think the state has taken some steps, but I just know that after Michael, we were down. I mean, just there's no communication at all. And that was really a helpless feeling. So I know that I think the state is working on things or already have something in place where you're not, like Dr. Nelson said earlier, you're not dependent on one carrier or one cell phone carrier. And that when that tower goes down, you're down. And just from a communication standpoint, beefing that up and making that the best that it could be, regardless of what's impacted, if it's the Keys or the Panhandle or Jacksonville, God forbid, you know, we could all be able to communicate with each other and central office.
Thank you. And just if I could ask, just as a follow-up, can you answer that same question in about 2 weeks? I'm serious. That any lessons that you learn over the next, hopefully it's none, but if there's anything that you learn over the next 2 weeks or so, if we could find a way just to gather that would be very helpful.
During the 2004 hurricanes, Charlie, Francis, and Jean, we had a system you may remember called Nextel, where it was like walkie-talkie system. Lots of folks in Florida used Nextel, including law enforcement. And when Nextel was not able to support their system, it went away. So, you know, again, don't put all your eggs in one basket. You've got to spread the wealth.
I'd like to ask Dr. Nelson if social media contributed or hindered the work of the Academy.
Not from anyone that I'm aware of. I don't know that our MEs around the state use social media, especially during a time of disaster. But again, in our state system, we have all of the back channel telephone numbers. We have all of the personal cell phone numbers of everybody that's there, so that we can continue to try to reach out and speak directly to somebody, so that we're not having to rely on social media as to 30 or 40 deaths in Jackson County that turned out not to be the case. We've got a cell phone number. We also, the Medical Examiners Commission sits within the Florida Department of Law Enforcement. This is our state police agency. So we have the ability to tap our state police agency and say, hey, we haven't heard from our medical examiner in County XYZ. Can you send agents over there and make sure that that place is up and running and everybody's doing okay? So it's definitely communication, but I don't know that we're relying on social media.
I was wondering if it contributed to the rumor mill.
Oh, I'm sure it probably did. I'm sure it probably did.
Yes, ma'am.
Just curious to know if you have ever mobilized ham radio.
Go ahead, Dr. Nelson.
I'm not aware of anybody mobilizing ham radio, but that would be a first responder. I don't know that that would necessarily be an ESF.
We actually had one in Jackson County.
Okay.
It was that was very unique and interesting to be a part and witness that. Yeah, we did.
But my experience is that they're always ready and always prepared and can
Provided the antenna's up.
can turn 1 watt into total communications.
It was really something to see, Mr. Bernard, and I had not, maybe I'm not old enough to witness that, but it was really something to see how that communication ping from one to another to another to another, and the language and all of that. So yeah, it was that was all we had. That's all we had after that first hour. Yeah.
So my suggestion would be, since you've witnessed it working,
Absolutely.
why not put in place a mechanism for mobilizing it immediately, because it's always there, always ready, and there's a very strong likelihood that nobody in that community will be a fake news merchant.
Good point.
Yeah, that's a good point.
Two questions. One is whether you've seen in the data that have come in a rise or something you believe could possibly be a rise in either suicide attempts, or drug overdoses, sort of in the 6 to 12 month aftermath of Michael. So that's one question.
I would say certainly that there's always that related to the storm. I don't know what the actual numbers are, but that's always on our radar.
And I was going to comment, we haven't looked at Michael, but we have, as I mentioned, we are working with Monroe County, Florida Keys, to look at suicides that do seem to be increasing in the Keys, and we're concerned that they're related or indirectly related to the hurricane and the disruption of homes and work and the life of the people in the Keys.
Thanks. And then my second question is, you talked a little bit about what your wish list of what you would do better in terms of data management. Are there data needs you can think of that if you had particular information, in the 2 weeks or the 3 months after the storm, would help feed back into ways that you're responding?
I would say that Florida's pretty well tried and tested. I think most of the areas, everybody's got a disaster plan. Our first commission meeting of the year, each year, we ask all of the medical examiner offices to review their disaster plan. My disaster plan's 98 pages, and it covers literally everything from nuts to bolts, with after-hours numbers for everybody, how to get in touch with them, what we're supposed to do for this, that, and the other thing. So from that stand, I think we're pretty well tested. Every 2 years, the Federal Aviation Administration requires a planning for disasters in airports. We have an international airport in my territory, so we're doing a tabletop 1 year. We're doing an actual on-field exercise the following year. So from a disaster preparedness plan, I think we're, and again with hurricanes all the time, I think we're pretty well tested.
Morning, thank you. Looking at Florida as a traditional receiver of evacuees, not only internal to the state, but traditionally from Puerto Rico and the Virgin Islands, is there any type of information connectivity on indirect death reporting or injury reporting that connects your efforts with the state health departments in the territories in the Commonwealth?
When we have a death, yes, we would want to know where that injury occurred. And again, I think we're limited by communication. If there's no communication available, for example, in Puerto Rico, we would be significantly hampered to be able to get the details for that death. That reporting may take longer than our everyday 4 o'clock conference call.
Assuming the communication networks are up and running, is that a formalized process, or is that based on personal relationships, direct relationships between you and your peers?
It would be a regular relationship in order to document what we need on the death certificate to ascribe the manner of death: homicide, suicide, natural, undetermined accident. So that would be something that each medical examiner office needs to be looking at. It wouldn't be anything that would be a special request or anything, but if somebody comes into the state already injured from elsewhere, that's something that we do all the time.
Yeah. I guess I have 2 or 3 kind of minor, sort of random questions. The special needs registries that you mentioned, are those available for research purposes, or is that not permitted? I'm just curious.
I would have to check on that.
That's a fair question.
Yeah.
And I'm curious also, when you're looking at those registries, et cetera, have you also looked at or hooked into the Empower system that HHS has put together for building off some of the Medicare, Medicaid data?
I don't believe so.
Okay. And then just kind of one last kind of random question. So we did a survey following the Northridge earthquake, and a couple of big needs that we hadn't really necessarily anticipated that came out were things like eyeglasses and wheelchairs and those kinds of medical devices. Do you capture any information around those kinds of things, which may not seem as high a priority, but obviously they're still very important for the people that are impacted?
Yeah. I think that's probably, we would be able to get information on that probably when they present to the special needs shelter. That's when we'd probably find out about that information, that they need a walker or they need some additional assistance with their care. Yeah. But ahead of time, I know that in our questioning, we do ask them to be sure to bring everything that they need when they present to the shelter. But yeah.
Okay, thank you.
Given that practically everybody under the age of 70 spends an hour a day on social media, either with Twitter or whatever, I'm asking myself how that wondrous capability can be used to promote the mission of what we're trying to do. And secondly, because all of the organizations represented here probably have a web page wherein they can post things that would be useful for the community and can also report information that is of interest to the community. Now, Dr. Nelson mentioned that he reports his data to the EOC. The EOC is the singular reporter of death data. Is that correct?
Distributor.
Distributor, okay. Do you also put that on your website?
No, ma'am. One person speaks for the state, and that's the Emergency Operations Center.
Do they put that on their website?
I don't know if they do or not, honestly.
Because these days, simply calling in the reporters for a press conference really doesn't do it.
Well, we've got press that's very active and aggressive in our Emergency Operations Center. Our EOC has been up and running since Wednesday, so I can't imagine that there are not people there that are just hanging, waiting for data.
So they would put that on their website?
They would release that once it's been reported to them.
So the reporters would put it on the Miami Herald or website or whatever. Is that right?
Yes.
Okay. All right. Thank you.
I can comment. This is not on data on. We've done some carbon monoxide messaging on social media. Although I have to say we have a lot to learn about how to use social media effectively. One thing we have been working on, which is a little post-impact, is to try to get out messaging about mosquito control, because what we realized last year after Michael was, or it might have been, it was Irma, sorry, too many of these storms, was that the anti-pesticide movement has perfected the use of social media. So we haven't had a great concern previously after storms when we have needed to do mosquito control, just to allow responders to work safely and without having to be concerned about a large number of mosquitoes. But because of the active use of social media by the anti-pesticide groups, there were communities after Hurricane Irma who decided not to do mosquito control, which we found very concerning. So we worked with the University of Florida and their communications center and developed messages, and both before storms, but we're hoping that we will be able to use their team, their university-based team, after storms to put out correct information on social media, both as academically reputable sources, which may be more positively received than the government putting out these messages.
Thank you.
Just a quick question for Dr. Nelson. You know, one of the problems we get into with determining cause of death is that some causes of death are treated very differently, whether it's a criminal event, you know, versus an expected, you know, death that occurs in a nursing home. Disaster deaths really fall into sort of a no man's land where there's no significant like root cause analysis or forensic analysis of the factors led up to it. Sometimes we do trip over, you know, carbon monoxide being a unifying thing, but if a woman, you know, is moved from a nursing home into a shelter, falls, breaks her hip, you know, has complications, we don't really get at what the contributing factors were there. And obviously the MEs aren't in a position to do that, but where does that intel land? Where do we start to put together some of the public health factors that might be correctable in future events to prevent that morbidity or mortality from happening again?
Well, I would say that in Florida, somebody that does fall and break their hip, that would be classified as an accidental death. The manner of death would be accident. So Florida law requires that that death be reported to the medical examiner. So those types of deaths that somebody gets evacuated, they go to the nursing home, as you say, or they're evacuated from the nursing home into a shelter, they fall, break a hip, go to the hospital for treatment, they die for that broken hip, those would be reported to the medical examiner. And the whole reason, again, proximity, what starts the ball rolling, is that they're evacuated as a result of the hurricane. So yes, we would count those as an indirect death. We only count the direct deaths of those that are actually impacted by the storm itself. Their car is blown off the road into a lake, a canal, a tree falls on their car, crushes them, tree falls on them. Those would be the direct deaths. But the other deaths, the carbon monoxide, the nursing home evacuation deaths, those would be indirect deaths that would be counted. Let me just provide the group with the 11:30 update from the National Hurricane Center. It is now projected to meet Florida as a Category 4 storm. So we'll have, not yet, somewhere along the East Coast, Melbourne, Daytona Beach area.
And sorry, one follow-up question, Dr. Nelson. Do you have any definition of what you consider an indirect death?
Again, it would not be the natural deaths of AIDS, suicide, AIDS, Parkinson's disease, heart disease, those types of things, unless they were directly impacted from the storm. Somebody, for example, with renal dialysis that could not make their appointment because the dialysis center is closed, because the dialysis center doesn't have electricity, that would most likely be counted as an indirect death. But otherwise, people that are in hospice care that die would not be counted as indirect deaths.
So if somebody was moving a portion of a tree and suffered a heart attack, that would be considered a indirect or direct death. But if a person happened to have a heart attack while in a shelter environment because of the stress of the event, my guess is that's not captured as indirect.
No, it would be captured. If they are in the shelter, they've been relocated for that reason, yes, it would be counted as an indirect death.
Okay.
Them clearing debris after the storm on their property, yes, that would be counted as an indirect death. If the storm is actually over them and the tree falls while they're out there doing something that they should be in shelter, instead of being outside, that'd be a direct death.
If they were in the home and worried about the hurricane during the hurricane and had a heart attack?
Difficult to say, but it would certainly require some review. But I can't give you a hard and fast on that. Probably not.
But this is really helpful because I think it's so important that I think what comes out of this is a taxonomy of what we consider to be causative and contributing factors.
And I'll freely admit this is more of a religion than it is a science.
And I think that's true. At the same time, I think we have an obligation to try to craft as much science as we can so that when we collect data, we're collecting it in a way that is uniform, that makes some sense according to some sort of established process, and that also we can communicate from the EOC or to others so that when we say that, you know, Hurricane Michael caused X number of deaths and contributed to X number of other deaths, you know, that's verbiage that the lay public, I think, can understand, whereas we start to get into starting to talk about indirect and delayed and contributing factors and things, you know, then people's eyes start to glaze over. So, you know, that taxonomy, I think, is really important to me that we get that right, you know, for going forward and for our research and other purposes.
Point well taken.
I'll just respond to that. I think we're going to have some presentations later that will look at that taxonomy, and you can see whether in fact it's complete or not and where it misses the boat. I will say that you can create all the taxonomy you want, but if, as in Puerto Rico, if people don't know what they should be putting down on a death certificate, it's not going to do you any good. So therein lies an issue. Yes.
Absolutely. But if you don't have the taxonomy to educate them on.
True. Yes. Ali.
Thank you. This was a quick response back to Marcella's and social media question. So social media is two ways. It's not just how do you communicate out to people. We don't use it enough to think about how do we learn what's going on in the community to sort of supplement our morbidity and mortality data, both immediately and long term. And so I think there's still an opportunity, and it's very nascent, but I think there's an opportunity to better use social media than integrate it with other data sources to better understand what's going on in the community.
Hopefully this doesn't come across as an unfair question, but as we move away from the response and into recovery and mitigation, which data are more valuable to you from a public health perspective, mortality or morbidity, and how would you use that data?
I'm looking at Sandon being the person who is working with the community the closest. I was going to make a point earlier that the one thing that I think is a lesson from these hurricanes and storms in Puerto Rico, the team from Puerto Rico that preceded us certainly articulated that as well, is that sometimes it feels like the resources and the response ends within a couple of weeks, whereas the recovery and the needs could take several years to get back to normal. So there certainly is a long-term issue. As far as acute disease issues, we have not done anything different than looking at our fairly substantial list of reportable illnesses that I mentioned include things that we would be concerned about after longer term after hurricanes with food safety and with exposure to environmental pathogens like Vibrio or leptospirosis or animal bites. I just found out the other day that we have an outbreak of rabies actually now in the area where Sandon works in the Panhandle. And whether that's related to the storm or not, I don't know, but certainly there's been a disruption of their ecology, and that may very well have impacted disease transmission. So the short answer is from me that we, unless we do get specific requests from the community, we do fall back and rely on our normal systems, which are fairly flexible. We can look for anything in essence. I mean, we get all the chief complaints data. We typically monitor for infectious issues, but we can monitor for we can search the notes fields, so we can monitor for diabetes, we can monitor for injuries, we can monitor for anything that there's a need to monitor for, but we haven't seen any real need to get away, for the most part, from our normal reportable disease issues. Suicide might be an exception to that, and we're just sort of entering into that arena.
I hate to cut people off, but we are a little bit beyond our time. I'm willing, which means that we're going to have a shorter period of time for lunch. That being, am I right? 12:30. 12:30. Great. Forget that, please.
I thought you were going to cut me off.
Please.
And again, this may not be a fair question, but I'm thinking, first of all, thank you all for being here, especially at this point in time. And we obviously wish you the best over the next few days. But you're in a lot of ways, you have developed a model system. And I'm curious as to whether or not you could reflect on why you have been able to develop such a robust system. Yes, you recognize that there's still things that you could be doing better, but you already have a robust system. And I guess I'll ask the question in two different ways. Is there something from a systems perspective, from a leadership perspective, that really contributes to the success you've had? Or the other way I'd ask it, if other communities, other states looking to replicate what you have done, what kind of advice would you give them? Or what are the pitfalls? Or what did you do that you would have done differently?
I think the one thing that is key in anything in forensic pathology is communication. So you have to have the ability to communicate on your good days, on your bad days, and that comes about by having everybody's cell phone number. There isn't a single person in the state that I probably don't have a policymaker, that I don't have their cell phone number, and that I can get in touch with them and they can get in touch with me. And it works very, very well. So that when there's a glitch, it's handled immediately. It typically doesn't make it to the news media, that it's handled. So from that standpoint, I think that's a good thing. How did the system come about? So that we don't have rumors of a death boat off the coast of wherever, where we're shuttling all the dead people so that the count is off. That's that's straightforward. We want an accurate count, and we want the public to know there's an accurate count, and this is what it is, and we're speaking with one voice.
If I may. Also, partnership. The partnership that Vitals and the Department of Health has with the Florida Medical Examiners, Florida Funeral Directors, the associations, continual communication. That's been big. As Steve said, the test he gave us earlier, our numbers match. That shows the ability to communicate, to work through, and to make sure that our final product is a final product. So, we still have things we want to do, but that's where we're at today. We're comfortable with it, but we still want to grow the system.
And as I said earlier, we've also got a state system, a state commission, and all of the partners at that commission are the policymakers in their own rights. That just works really, really well. All the players are at the table.
Aaron?
So continuing the unfair questions, I guess I'm going to ask a question to kind of build off of what Charlie mentioned around, if you can build a great system, but, you also need to think about how to train people and get them to use it properly. The way that you've approached the mortality is an interesting one, kind of rolling it up. But if you're thinking about morbidity, I wonder if that's really as feasible. I'm reminded of a study that was done in Florida, and I guess this is the unfair part, where we talked with a number of, I'll say, healthcare providers in North Central and the Panhandle areas, and the former State Department of Health commissioner was part of the interview teams, and he asked everybody whether they'd heard about any training around bioterrorism or other kinds of disaster events, and the answer that he uniformly got was no, and whether they knew of any venues or ways that they could get that training, and they said no. And it was particularly depressing to him because he was the one that made the funding available, that pushed for those things to happen, and the satellite devices with the video cameras and the TVs, et cetera, were in the rooms when he asked them, and people still said no. So I'm wondering, how do you get people trained to use systems properly around something like this, that even in a place like Florida, unless they get hit repeatedly, I wonder how much people really pay attention, if it doesn't happen frequently enough. That's the unfair part.
From a forensic pathology medical examiner's standpoint, we have a meeting every year. It's open to anybody who wants to come, whether they're from Florida or not. It's a training event. Continuing medical education credits are available. So that type of training is available, throughout the year. So I guess the question I would have is, who is he asking? Who are those healthcare providers? Because, the folks that deal with disasters all the time, particularly the forensic pathologists, know what's out there. We at the state level drill upon it all the time. Disaster preparedness, disaster planning. And as Sandon said, all you have to do is be involved in one of these events one time and get caught with your pants down, and that will never happen again. So maybe there is some baptism by fire, but I think that everybody is pretty well tried and tested.
I mean, in fairness, the people that I'm talking about are more kind of your primary care kinds of people, the front line physicians that, from their perspective, are more concerned with trying to get somebody to stop smoking. And how do you get through to those people who, for morbidity or other things, may be important to try to capture this granularity that we've been talking about?
I don't have an answer for you. I know when I do outreach to our hospitals and that of what is and what isn't a medical examiner case, for example, the folks that show up are typically the psychiatrists and the dermatologists who don't complete death certificates. The folks that actually need that CME or whatever are not the ones that show up to hear the talk. So I'm with you. I hear you. I don't know how to make that better, even though the hospital provides, lunch and CME credits and all that. Those people that come are not the ones that need it.
So from our perspective, as far as the surveillance systems that we use, these are surveillance systems that don't sit on the shelf until we get deployed for hurricanes. We use them every day. And I think that's been really an evolution, where the syndromic surveillance back in the day started out being specifically focused on detecting individual cases of anthrax and so forth. And we realized that probably wouldn't work very well. But we then have been able to, because of the flexibility of the system that we use, to use the system in many other ways. And that we also, of course, run queries every day for anthrax and so forth also in the system. So everybody uses those data, and it's been a shift, I think, in local public health from what used to be a nursing-based team to include more persons who have a master's in public health training and more analytical skills. So I think that's really been a trend. As far as primary care providers, we absolutely have that challenge of most of the time the rare disease is not the first, probably not even the 10th disease that they've thought of before they eventually report it. We have more success working with, certainly with the automatic laboratory reporting, where we get most of our cases through that system, and then working with physician champions, but also infectious preventionists who have routine contact with the health departments and report cases to us.
A quick question from the conversation earlier about reporting direct and indirect. And when you report them to the EOC, to speak with that one voice, are they reporting direct, or are they reporting indirect, or both?
What they're reporting are some modifier, or some identifiers. They're reporting the county that death occurred, the age and sex of the individual, and the cause and manner of death, and how the injury took place.
And when you were talking earlier, that you said you agreed with the number of 65, it was, I believe, for Michael.
Well, 65 was Andrew. I think for Michael, we're at 52, 59?
52.
52.
Is that both direct and indirect?
Yes.
And when, the reason I ask is if the EOC says, oh, there was 40, but those were just direct, and then the indirect, so they always report both?
That is correct. They'll break it down as to direct versus indirect, and they'll have a little descriptor, a sentence or two, as to how the injury occurred. Yep.
I would like to ask Dr. Nelson if he would agree with me that one of the critical elements of his system's success is that death, the cause of death, and whether it's direct or indirect, depends on determinations by skilled physicians, as opposed to systems where determinations of cause of death and manner of death and the presence or absence of injury is dependent on, say, an elected person who is 18 and free of a felony, which is one of my major hobby horses, because the key to successful information is that you have competency at this lowest level. Secondly, now you mentioned that it was difficult to educate folks on the signing of death certificates. I have a suggestion. The Commonwealth of Virginia just required me to take 6 hours of training in opiate prescribing, and I have not written a prescription in 40 years. But there was no exception for me, even though I'm a pathologist. So your Board of Medicine can do what I hope Virginia's will, and that is institute mandatory training. You want to renew your license, honey? You take 2 hours of how to sign a death certificate.
Well,
Would you lobby for me, please?
and you mentioned the 18 and not have a felony. There's also a state that says that in order to be the coroner, you can never have fought in a duel. So let's not forget about how important fighting in a duel was. The short answer, Marcella, is no. Florida, we have tried for a number of years to get the Florida Board of Medicine to do exactly that, to institute some training for how physicians complete death certificates. We've been fought tooth and nail by the Florida Medical Association for that. They say there's enough information out there to accomplish it. But you're absolutely right. I too have to take the opiate prescribing course in order to renew my license as well. That's the uphill battle that we're fighting.
It would make a nice recommendation.
I would agree. Absolutely. Go for it.
When you come to Florida, I'll hire you as a lobbyist. Thank you.
I could do that.
Other questions?
I guess this may not be a question either. I have a habit of not asking questions. It strikes me that if you're dealing with something that is an occasional occurrence and not a routine occurrence, forcing people to take required training is not going to work very well, just because people aren't going to remember it. It's like this is the worst way possible to learn things, is to be forced to sit in the lecture hall or go on a webinar and listen to something. So I would think about other options, starting with making the system so intuitive that you can't screw it up that easily, that you don't need training in advance. Having just-in-time training for people as they're going through it so that they learn as they need to know, rather than trying to teach people in advance something that has no salience to them at that moment. Or I really liked what Karina referred to earlier, building a system that they do actually use all the time and then building from that. So it becomes a part of routine, and we talk about this in public health a lot, like using the annual influenza vaccination campaign as a way to get people to understand how we would deal with a pandemic or another outbreak. I'm not necessarily opposed to required training, but I'm generally opposed to required trainings.
I mean, we've seen so many cases where states have put in mandatory training for infection control on HIV and all sorts of other things that have been really well-meaning, and they've kind of gone by the wayside, and they just don't have that much effect. So I agree. I think some education ahead of time is a good thing. I think just-in-time education is a good thing. And I think to the degree that you can't, manipulate the report of death forms, then for a disaster, maybe we need a supplemental worksheet for coroners, to work through to say, is this a disaster-related death? Does it meet these criteria? Something like that.
Sorry, I did actually have a question. I just forgot what it was.
I think we have a response.
Oh, good, excellent.
And what you were saying, I mean, we've tried everything. We have voluntary training. We go to med schools. We try to do training on that. Residents, we hit all the hospitals as the residents are there and do training there as to how to complete death records. Anywhere we can get a physician to try to do training, we do. Some of it's helpful, as you say. Some of them never sign a death record for 5 or 6 years down the road. So we are open. Any suggestions on how to continue? If it was required, I think that would be helpful. Voluntary training we continually do, and we still look for ways for improvement.
One of the things that Florida does have with the EDRS system, Ken, correct me if I'm wrong, are pull-down windows. And if you, Joe
right.
Blow, the physician, pull down the wrong window, and you're going to say they've died of, blunt head trauma, no, you're not going to be able to complete that death record. That's going to be required to be reported to the medical examiner. So that's a built-in system that we do have.
Yeah, there's edits all through as to who can do what and whether, and even with that, our nosologists go through a lot of these too, looking at them. So we may query a physician back and go, this isn't clear, or are you sure? So even with that, we'll get back with physicians on certain manners.
So my question was related to that, because it seems like, if I'm understanding correctly how the system works in practice, you don't actually require the person filling out the death certificate to make a judgment as to whether it is direct or indirect, causal, non-causal. You're asking them a series of questions about the death, and then someone else uses criteria to say that qualifies as direct or indirect?
I think there's two different things. The personal physician would not be responsible or would not even be in the loop on a direct or indirect death. So the person who's doing that determination is the medical examiner. So yes, it is the medical examiner, not the nosologists at Vital Statistics, that make that call on whether it's a direct or indirect death. Yeah, that determination is made even before we report it to the EOC.
Would it be possible for us to get the guidance that they use to make those determinations? There must be something written that says if this, and this, then it's direct. If this, and this, then it's indirect.
Again, in a nutshell, if it's the approaching storm, it's a direct death.
Yeah,
if it's due to the storm itself, it's a direct death. If it's the approaching storm, you're doing preparations or you're doing cleanup, it's an indirect death.
Yeah.
I think we've received some documents on this, and I believe there'll be some conversation about this in some other sessions today and tomorrow. I don't mean to put you off, but yes.
A relatively simple but politically loaded question. How can data that you all generate be exploited to assist medical industrial complex decision makers, pardon my politics there, the CEOs of hospitals and nursing homes to make a rational decision about preemptive evacuation as opposed to waiting for a rescue phenomenon, which we saw this in Panama City, essentially, with Michael. We've seen it elsewhere. How do we help inform? These are 90% privately owned, operated facilities. They're not public facilities. So how do we use the information you have to inform those folks about the risk environment that they're entering into in making those decisions?
I don't know that I have an answer for you.
The only thing I can say is that as far as the incident management team, that the Health and Human Services agencies in Florida have been more outside of the Department of Health, who are involved in regulating hospitals, have been more engaged since we had the situation down in Broward with that nursing home, to make sure that that those evacuations, for example, did eventually occur, although at a late point in time.
This operationally is a real issue because mounting a rescue operation is a wholly different problem than assisting in a planned evacuation. And it has risks. And so the question of, are there deaths related, is that they're going to be small numbers relatively. But
Maybe not.
Are they compelling enough that you can take those numbers to those decision makers and say, here is the risk profile that you're entering into. Make your decision early.
I definitely agree. We have a hospital in Tampa General. It's at sea level. It's right on the coast. Yeah.
One last question.
And it'll take 1 second. So, Dr. Nelson, do all deaths go to the medical examiner?
No, sir. Only those deaths that are defined by law. That's our particular Chapter 406 of Florida Statutes, Chapter 11G of the Administrative Code. They deal with typically the non-natural deaths.
All other deaths would go through vital statistics and then would be disseminated through the department for use.
So there's a triage that happens immediately when somebody dies to say, I think this meets whatever the legal criteria is before it gets to you. So there's a whole set of potential indirect deaths and direct deaths that you potentially don't get to see. Is that true?
No.
No, I don't think that's true at all.
That's not correct.
We see the direct and indirect deaths in our state. There are no large numbers of direct or indirect deaths that do not go through the medical examiner system.
That's hard to believe then.
If you think about what the direct deaths are, though, the direct deaths are the direct impact of the storm. So those are straightforward. That Joe Blow, the personal primary doc, is not going to sign those death certificates. The indirect deaths are those that are preparing for the storm and something happens to them. They fall off the roof, they're hit by a tree, they die of carbon monoxide. Same thing with the indirect deaths after the storm. So those are not the deaths that the personal physician is going to be signing either.
But I'm still curious, though, how an asthma or a cardiac case that occurs in a shelter or something that might be, or occurs in a private home that is related, might, escape that. I think the key thing here is that ME cases are defined in most states by statute, those that get looked into and those that don't, and yet there's that contributing deaths, that disaster contributing deaths group where there's medical conditions exacerbated by disasters that I think there's a potential there, even if there's no potential in Florida, which has a really exquisitely attuned system, there's a major potential in at least other jurisdictions, other states, for those to really fall into a gray area.
It's a very outstanding conversation. Yes.
Most medical examiner coroner systems have a system wherein a death certificate that reports a death that should have been referred to the medical examiner bounces like a very bad check. And then that death certificate goes to the medical examiner, who, like I did, sat there and looked at a pile of them to see who I had to call to straighten out this death certificate. And so you catch them one end or the other if they put an actual competent diagnosis down, even if they didn't report it. Now, I used to worry more about the inability of some clinicians to actually recognize a traumatic death, which is a commonplace event where you don't have expertise at the very lowest level.
So can I? So I think that what this discussion brings up is that we probably need a third category of direct and indirect and contributing. And I think that contributing is probably unlikely to show up on death certificates, but be estimated in some other way.
Actually, there is a contributing portion on the death certificate, but that's an issue, and I think this type of discussion will flow right into some of the other sessions. I'm not trying to, but this is, you're right on, okay? Okay, so we're really out of time. One of I would like to point out one thing, though, is that I think, without pointing fingers, when we have a natural disaster or that MEs are involved in here in Florida, it may be a very different situation than in another state which doesn't have either a centralized medical examiner system and is dependent upon elected officials who may or may, some are very, very good, by the way, but some may not have the appropriate training. And therein lies some issues. I don't know if what we can do about that, because that's been in place in the United States since the beginning of the vital records system. But just to let you know that is an issue. So with that, I want to thank all the folks from Florida for really a great discussion, and you all as well.